Thank you, Chair Scott and Ranking Member Gillibrand. Communities in my state and all across the country face dire physician shortages, as this panel has demonstrated. Estimates are that in just a couple years, we'll be short by tens of thousands of doctors. Mr. Feist, what effect will additional workforce shortages have on our current health professionals, many of whom are already facing burnout?
Reductions in staff are a force multiplier on the issues that we've been talking about on this committee today. We have to look at what our clinicians are spending their time doing right now. And when you look at the fact that about 70% of a primary care physician's time and 50% of a nurse's time spent away from the bedside, away from the patient, spending that time on administrative burden, as you decrease your staff, who else is left to do the administrative work? And so it's this vicious cycle that will impact access, it will impact quality, and it will impact cost over time.
So it's an impact, obviously, on the workers, including the physicians and their workplace, but it's a real effect on patients.
Absolutely.
And the quality of the health care that they're able to provide. For decades, Medicaid has helped fund doctor residency training through the Graduate Medical Education, or GME program. And this program has played a critical role in addressing physician shortages in states like Georgia, where more than 2.7 million Georgians live in a health professional shortage area. But it's clear we need to do more. That is why I was proud to introduce the bipartisan Resident Physician Shortage Reduction Act alongside my friend Senator Bozeman. This bill would fund 14,000 new resident slots over the next 7 years. Mr. Smith, how would an increase in Medicare-funded graduate medical education slots help improve our seniors' access to healthcare services?
I think any addition of physicians into the market would increase access to care. There'd be more appointment time and more availability. The challenge we have is convincing those doctors to go into primary care, internal medicine. Most of them nowadays, they say, I want to become a neurosurgeon, or I want to become an EP doc in cardiology, because there's more money there. They're trying to pay off their student debts. They spend another year in fellowship. So we don't see a significant amount of docs wanting to be family practice doctors anymore. And I think somehow we've got to incentivize that in this program to make that more attractive. Make that the noble position that it used to hold in the community. Take some of this administrative burden off of them and let them be doctors again. The numbers are great. We need the numbers. We know that the shortage by 38 is going to be staggering.
Absolutely.
So I think
they're making decisions then about the direction of their career and what they will be able to practice, not necessarily based on what they prefer to do. Some would love to go into primary care. It's an economic issue. In that regard, Dr. Littles, in your experience, how often does the cost of higher education in the health professions dissuade people from entering the field?
Thank you for that question. We certainly believe that that is a factor because, as I said, when students come into medical school, they come because they really want to be able to provide care and spend that time, with their patients. But they also need to be able to make a living. And doing that, and as has been said, it's the primary care specialties that are the hardest hit with that because they tend to be at the lower end of the pay scale already.
Right.
And if you're asking them to do more and more for less and less, at some point that just doesn't work, for them. So if we're able to fix some of these other issues with those practices, I believe those students who come in wanting to take care of patients in a primary care setting will continue to want to do that and will continue to do that.
Absolutely, and I would I know this is particularly difficult for first-generation college students who've gone on to medical school and are, they have the aptitude, but you have these barriers. In the last few months, I've heard from thousands of Georgians about changes to federal loan limits under the Big Ugly Bill, which cap the maximum amount of federal direct loans available to students pursuing a health profession. Most medical and nursing students in Georgia rely on federal loans to afford their education. And when federal loans are capped, students seeking advanced degrees in healthcare still owe the rest of their bill. And those who don't come from rich families have to then try and get risky private loans from banks, or worse, put their tuition balance on high-interest credit cards, or even just give up their dreams of being a health professional altogether. And so this is a concern that all of us share. I appreciate your work in this area, Dr. Little, and also other members of the panel. And I'm deeply concerned that these changes to the federal student loans amid a growing healthcare workforce shortage and aging population is the exact wrong move at the exact wrong time. Thank you so much.
Thank you,